Good morning. My name is Dr. Sherine Gabriel. I'm professor of medicine, rheumatology, and epidemiology, and I'm here to present Cardiovascular Grand Rounds on cardiovascular disease in patients with rheumatoid arthritis. Here are my disclosures. My objectives today are to summarize research findings regarding the risks and outcomes of heart disease in rheumatoid arthritis patients compared to similar patients who do not have RA, focusing in particular on cardiovascular death, ischemic heart disease, and heart failure, to describe the role of cardiovascular risk factors and cardiovascular risk scores, as well as potential biological markers for prediction and prevention of heart disease in persons with rheumatoid arthritis, and to discuss implications for patient management. Much of the research that I will present today comes from the Rochester Epidemiology Project, and as you can see here, that project covers all inpatient and outpatient care for a geographically defined population, Olmsted County, encompassing the 125,000 people who live there. And as well as the city of Rochester. And the Rochester Epidemiology Project represents almost complete ascertainment of all health care, inpatient, outpatient, regardless of provider, and health outcomes that occur in this population. The overall study design involves assembly of a rheumatoid arthritis cohort, an incidence cohort of about 1,200 patients to date, beginning with RA patients first diagnosed back in 1955 and going all the way to the present, a comparison cohort, non-RA comparison cohort about the same size, also with follow-up to the present, as well as other comparison cohorts, CHF comparison cohort and an MI comparison cohort. So depending on the question, we required a different kind of control group, a different kind of comparison cohort, non-RA or a cardiovascular disease comparison cohort. We looked at risk factors and major outcomes. So this is the only mortality slide I will show, just to remind you that cardiovascular survival free of cardiovascular death, is still significantly worse in persons with RA compared to persons without from the same population. And you can see here RA shown in yellow, non-RA shown in green, and there's a significantly worse survival among persons with RA. In this slide, we're referring in particular to cardiovascular survival. With respect to ischemic heart disease, I'm just going to highlight some of the key findings that I will share with you. We'll share with you some data showing the increased risk of ischemic heart disease in rheumatoid arthritis, that ischemic heart disease precedes RA and is often, in fact, silent, presenting first with sudden cardiac death, that the presentation of myocardial infarction tends to be different in persons with RA compared to patients who do not have RA, and that mortality after MI is higher in persons with RA compared to non-RA subjects. Data that we've also published on, but that I will not share today, shows that RA patients are not any less likely to undergo acute reperfusion therapy or other kinds of cardiovascular treatments for their ischemic heart disease. So first off, the prevalence of ischemic heart disease in RA, shown here in an analysis comparing about 600 patients with RA and 600 patients with non-RA, right at index date or incidence date for persons with RA. So what this shows is that even at the time RA patients are first diagnosed with the disease, they are already at a threefold higher rate. They already have a threefold higher rate of having had a hospitalized MI, almost a sixfold higher rate of having had a silent MI in their medical record, about half the odds of having had angina, and about the same odds of having had revascularization procedures. So what this tells us is at the time of diagnosis for persons with RA, they are already showing that increased risk for ischemic heart disease. These slides illustrate the same risks, but beginning at incidence date or index date and going forward. As you can see, each one of these slides begins at time 0, which is the time of diagnosis of RA, and goes forward in time. And you can see that persons with RA have significantly higher rates of silent MI, significantly higher rates of sudden cardiac death, and for some reason that we don't fully understand, lower rates of having reported angina, and that has always been a bit of a mystery. When we compare persons with RA who have myocardial infarction compared to those in the general population with myocardial infarction but who do not have rheumatoid arthritis, the outcome is different. Persons with RA have a significantly higher rate of mortality, as shown here in the yellow line, compared to persons who have MI who don't have RA, shown in the green line. So the standardized mortality ratio is 1.47, a significantly higher rate of mortality after MI in persons with RA. So moving on to heart failure. Some of the data points I will share with you include the now well-known increased risk of heart failure in persons with RA that persists even after adjustment for known risk factors, that the clinical presentation of heart failure among persons with RA seems to be somewhat atypical, that heart failure in RA patients is more likely to present with preserved ejection fraction, and that mortality after heart failure is significantly poorer in RA compared to non-RA subjects. And finally, that RA patients without clinically evident cardiovascular disease have a higher prevalence of left ventricular diastolic dysfunction. Data that has been published, but I will not share with you today, are that RA patients with heart failure tend to be managed less aggressively, and that patients with RA and heart failure have a higher rate of hospitalization, longer hospital stays than patients with heart failure who do not have RA. So first of all, the cumulative incidence of heart failure. Again, RA shown here in yellow, non-RA shown in green, and you can see that over time, beginning at incidence date for rheumatoid arthritis, comparable index date for non-RA patients, that people with RA accumulate more diagnoses of heart failure over time. And this difference is highly statistically significant with p less than 0.001. The kind of heart failure that we see in persons with rheumatoid arthritis also tends to be a little bit different. So this slide shows ejection fraction among persons diagnosed with heart failure who do not have RA, non-RA, and persons diagnosed with heart failure who do have RA, as shown here. And as you can see, the odds of having heart failure with preserved ejection fraction is almost twofold higher in persons with RA compared to those without. And that is even after adjustment for known heart failure risk factors. As we saw with ischemic heart disease with MI, persons with RA are much more likely to die after heart failure compared to people who have heart failure but who don't have rheumatoid arthritis. So again, here we have rheumatoid arthritis shown in yellow, non-RA comparison group shown in green, and mortality following heart failure is statistically significantly quite a bit higher in persons with RA compared to those without. And as you can see, the 30-day odds of dying following heart failure is 2.57, so almost 2.6-fold higher in persons with RA compared to those without. So with all of this information, what can we do about predicting and preventing cardiovascular disease in persons with RA? So first of all, we looked at cardiovascular risk scores and cardiovascular risk factors to see what these things can teach us about predicting and preventing heart disease in RA. And what I'll share with you is some data that shows that the traditional cardiovascular risk factors, those risk factors that we rely upon to help us understand who's at high risk and who's at low risk in the general population, are somewhat less important in persons with RA versus those without RA. And that's because there are other competing factors, likely factors associated with the underlying systemic inflammatory disease that are increasingly important in persons with RA. And in fact, some traditional risk factors behave in a paradoxical fashion in persons with RA compared to those without. I'll also show you some data that shows that conventional risk scores generated for the general population perform poorly in persons with RA. So on the left-hand side of this slide are data from our own team, and on the right-hand side is a report from the Nurses' Health Study, basically both of which showing that traditional cardiovascular risk factors are not any more common in persons with RA compared to those without. So one possible explanation for the increased risk of cardiovascular disease in people with RA is that maybe people with RA have more of the traditional risk factors, more diabetes, more hypertension, more hyperlipidemia, but neither we nor others find that this is the case. In addition, some traditional risk factors behave in a somewhat paradoxical manner. So the graph on the left comes from a paper from Escalante and colleagues, and the graph on the right is from our own team, both of which showing that low BMI is actually, in persons with RA, is actually associated with an increased risk for cardiovascular disease. And that relationship is not what we see in the general population. In fact, it tends to be the other way around in the general population. And we believe that low BMI in persons with RA might be an indicator of active or poorly controlled systemic inflammatory disease. Likewise, in rheumatoid arthritis, we see a paradoxical effect for lipids. So this slide shows total cholesterol on the horizontal axis and hazard ratio for cardiovascular disease on the vertical axis. And what you can see here is that at the lowest levels of total cholesterol, there is an increased risk for cardiovascular disease. And again, that's a paradoxical relationship from what we see in the general population, where in general, higher levels of lipids increase or indicate an increased risk for cardiovascular disease. This is looking at those same data, perhaps with a little bit more information, and in this case, information about the impact of inflammation on this paradoxical effect that we see with lipids. So as you can see, with very low levels of inflammation, and here the horizontal axis shows erythrocyte sedimentation rate, a crude indicator of inflammation, and again, hazard ratio for cardiovascular disease on the vertical axis, you can see at very low levels of ESR, low levels of inflammation then, the relationships that we see between risk of cardiovascular disease and lipids is what we generally see in the general population. That is, individuals with a total cholesterol to HDL ratio of 6 in the dotted green line have a higher risk than individuals with a total cholesterol to HDL ratio of 2, shown in the yellow line. But when we look at higher ends of the scale with respect to inflammation, so at SED rates of 50 or more, that relationship becomes completely flipped. So at high levels of inflammation, a total cholesterol to HDL ratio of 2, which is considered good in the general population, is actually associated with an increased risk for cardiovascular disease, and a total cholesterol to HDL ratio of 6 is actually associated with a lesser risk for cardiovascular disease. So again, in the context of inflammation, it appears that lipids behave in a paradoxical manner. So what does this all tell us about how scores such as the Framingham risk score, probably the most commonly used risk scoring method in the general population, how does that perform in persons with RA? Well, interestingly, it performs very differently depending on whether these RA patients are seronegative or seropositive. So seronegative for either rheumatoid arthritis, rheumatoid factor or CCP, or whether they're negative for those markers. So in this case, in this slide, I'm showing seronegative women and seronegative men with the yellow line indicating observed 10-year cardiovascular risk, and the green line showing predicted cardiovascular risk based on the Framingham risk score. And as you can see, the Framingham risk score really performs pretty well in seronegative patients. In fact, it performs about as you'd expect in the general population. The situation is different, however, when we look at seropositive women and seropositive men. And here, the observed line, again in yellow, and the predicted line in green indicates that the slope is entirely different in patients with seropositive rheumatoid arthritis compared to what we would predict. So in other words, the Framingham risk score in these cases does a very poor job of predicting risk in seropositive and seronegative men and women with RA. And in fact, what we see is not simply an elevation of risk. In other words, persons with seropositive RA, their risk does not simply look like somebody who doesn't have RA who's 10 years older or even 20 years older, shown here in the dotted lines, but there appears to be an acceleration factor. That is, every year that a person in the general population would age, the individual with RA, their risk increases not by 1 year of age, but by a factor of 1.2-fold higher. So there appears to be an acceleration factor that makes it impossible for us to simply add 10 years of age and get a good estimate for risk according to the Framingham score. And these are some other data that just demonstrate that the Framingham risk score really doesn't help us very much with respect to estimating risk in persons with rheumatoid arthritis. Again, observed risk is in yellow, predicted risk by the Framingham score is shown in green, and as you can see, in many of the categories of predicted risk, the observed is higher than the predicted, but the proportion by which it's higher differs, and in fact, in some categories, the observed approximates predicted, and in one or two categories, it is even less than predicted. So the bottom line here is that the Framingham score really does not help us very much in terms of predicting risk in persons with rheumatoid arthritis. So in conclusion, persons with rheumatoid arthritis die prematurely, largely as a result of a higher risk of cardiovascular death. Ischemic heart disease occurs at a higher risk and higher rate in persons with rheumatoid arthritis, and often presents with silent MI and sudden cardiac death. It may occur early and without warning. Heart failure also occurs at a higher rate in persons with rheumatoid arthritis. The presentation of heart failure tends to be somewhat atypical, much more frequently with preserved ejection fraction. And once people with RA develop heart failure, they tend to have a higher mortality rate associated with that compared to others with heart failure in the general population. I didn't discuss this with you today, but we've also seen that myocardial dysfunction, especially left ventricular diastolic dysfunction, precedes heart failure in persons with RA. And new tools such as strain echo can help us potentially identify individuals with RA that are at particular risk for diastolic dysfunction. Persons with RA have worse outcomes after cardiovascular disease, not only heart failure, but ischemic heart disease, and a higher utilization of hospitalization and health services after developing cardiovascular conditions. So what does this all mean with respect to patient management? Well, the traditional cardiovascular risk factors that we rely upon to help us understand risk and manage risk in people within the general population are much less helpful in persons with RA, and some of them even behave in a paradoxical manner. And that's because inflammatory markers are strong independent predictors and perhaps compete with these traditional risk factors, sort of muddying the picture. General population risk scores, such as the Framingham risk score, perform poorly in persons with RA, and that points to the need for developing RA-specific risk scores and RA-specific biomarkers. RA drugs, again, didn't discuss that today, but RA drugs like non-steroidal anti-inflammatory drugs, glucocorticoids, methotrexate, biologic and non-biologic DMARDs, all have complex multifactorial effects on cardiovascular risk. some of them through interaction with cardiovascular risk factors such as lipids. Observational studies have taught us a great deal about the risk of cardiovascular disease in patients with rheumatoid arthritis, but really the next step to understanding how to predict and prevent these conditions will require randomized controlled clinical trials. Now, these will take a long time and they'll be very costly. What do we do in the meantime? In the meantime, we believe that multidisciplinary care offers the best option for management of these patients. At Mayo Clinic, we have created what's called a cardio room clinic, where preventive cardiologists along with rheumatologists collaborate on how to best manage patients with rheumatoid arthritis with respect to their cardiovascular risk. And so in this clinic, we provide individualized cardiovascular risk assessment. A cardiovascular risk profile tool is used for all patients. We do the usual fasting lipid screens, but in addition to that, we do an arterial health screening study as well as an echocardiogram with strain assessment. We determine the need for further testing and or pharmacotherapy depending on the detailed evaluation and collaboration discussion between the preventive cardiologist and the rheumatologist, taking into account disease-related risk factors such as RA disease activity and RA treatment. So, just in closing, I'd like to acknowledge a very large team of individuals that contributed to generating this knowledge and is continuing to help us better understand the risk of cardiovascular disease in persons with RA, and most importantly, clinicians in the divisions of rheumatology and the division of preventive cardiology, and most importantly, our thanks to our patients for teaching us about this. Thank you very much for your attention.